Hello and welcome to my presentation based on my literature review. Does aquatic exercise improve balance in people with osteoarthritis? I'll start by talking a little about osteoarthritis, or OA, and its relevance to balance and water. OA is a joint disorder occurring when excessive loading or stress causes damage over time, which then triggers repair processes and causes pain and inflammation. It is a leading cause of disability worldwide, with over 8.75 million people seeking treatment in the UK alone. Prevalence increases with age, occurring in 80% of over 65s, and is more common in women. It is associated with balance disorders, which increases falls risk. Over 50% of people with lower limb OA report to fall each year. Falls cost the NHS £2.3 billion annually, and interventions aiming to improve balance may reduce falls risk and help reduce the costs to the NHS. The warmth and buoyancy of water helps reduce pain and loading on joints, therefore making it advantageous over land exercise. Previous research shows that aquatic exercise has significant positive effects on functioning, pain and stiffness in people with OA. However, no reviews analysed the effect of aquatic exercise on balance. Therefore, the aim of the review was to determine the effectiveness of aquatic exercise as an intervention to improve balance in people with OA. 11 databases were searched using a Boolean search strategy and their equivalent synonyms. After limiting articles to those peer-reviewed and in English, and removing duplicates and those failing to meet inclusion criteria, 5 studies remained. Studies were excluded if they did not assess balance or failed to include an intervention that performed exercise in water, for example, spa therapy. Studies were also excluded if participants had neurological or cognitive diseases, and these are not representative of the population. A clinical diagnosis of OA was required in all participants. Studies had to perform a within-group analysis of the aquatic intervention, as this was important for analysing results. 5 studies, including 4 randomised controlled trials, met the criteria. Collectively, there was 165 participants, of which 141 were female, with an average mean age of 66 years. Sessions progressed weekly in all bar 1 study, from 20 minutes to 1 hour. 4 of the 5 studies performed 2 sessions weekly, and programmes ran between 3 and 12 weeks. Common outcome measures included the step test, timed up and go, or tug, and the single leg stand. Of the 4 studies to produce post-intervention outcome data, all demonstrated improved balance post-aquatic intervention in all outcome measures, and 3 produced statistically significant improvements. Overall, there is moderate evidence that aquatic exercise improves balance in people with osteoarthritis. Methodological quality was assessed using a modified version of the Downs and Black's 1998 quality assessment tool. There was potential that 3 studies failed to meet the calculated power analysis, which means they may have had sample sizes too small to detect any statistically significant differences. Therefore, the conclusion exercise does not improve balance in people with OA cannot be inferred from their non-significant results. 3 studies failed to report probability values. Therefore, the strength of evidence was unidentifiable, reducing the credibility of the conclusions. No studies blinded participants to their intervention. However, this is challenging in physical rehabilitation. As patients' beliefs regarding the intervention may have altered results, performance bias is increased. The collated results suggest that 2 to 3 weekly sessions for 12 weeks increases the chance of producing significant changes. Short duration, high frequency programs may also be effective. However, the feasibility of this within the NHS should be considered due to high staffing requirements and availability of pool hire. More research would be beneficial to identify if program durations between 8 and 12 weeks would be equally beneficial. Both upper and lower body exercises should be included, likely because both upper and lower body movements contribute equally to maintaining balance. Stretching, strengthening, aerobic and balance-based exercise should all be included in the programme. The available evidence makes recommendations for intensity difficult. It seems progressive programs yield the best results by either increasing repetitions and sets, increasing resistance, or increasing session time. We will start this discussion piece by clarifying the difference between static and dynamic balance. Static balance is balancing whilst stationary, whilst dynamic is balancing whilst moving, for example, walking. The evidence could argue to favour either. 2 of the 3 studies to produce statistically significant results used the same dynamic step test measure, suggesting favour to dynamic balance. However, another dynamic measure used, the tug, failed to produce any statistically significant results. What was interesting was that all 3 statistically significant results were also clinically significant results. The study to measure single leg stand improved from a baseline time below 30 seconds to above 30 seconds, a clinically significant marker to reducing falls risk. In the studies to conduct the step test, a score of 11 steps, or an improvement of 3 steps, is associated with reduced falls risks. Both studies to use this outcome measure achieved these results post-intervention. As that was a lot of information to consolidate, this slide provides you with a summary of my findings, including the recommended guidance to follow to maximise improvements in balance when designing an aquatic exercise programme for people with OA. Thank you for listening.